Everyone, my name is Mirabel Forteh. I'm a DNP student at Mirabel University, presenting my DNP scholarly project on decreasing heart failure readmission rate through early outpatient follow-up and education. And my committee members were very influential in getting me through this project up to this point. And I want to deeply express gratitude to them for all the work they put in the background. Um, I have my DNP chair, Dr. Jennifer Hubner, my second reader, Dr. Wonderlick, my community person, Dr. Trad. The significance. In the United States and project site, which is my current place of employment, heart failure remains a significant problem associated with frequent hospitalizations and readmissions for patients over the age of 65. The project aimed to determine if implementing early post-discharge follow-up lowered the heart failure readmission rate post-intervention compared to pre-intervention. The PICO question, now just read it as it is. For adult patients discharged from the hospital for heart failure, does early post-discharge follow-up defined as a 24 to a 48-hour telephone call followed by a scheduled 7 to 14-day office visit compared to no follow-up reduce the 30-day heart readmission rate? So we'll go on to our next slide, the background. At a hospital located in the southwest region of the United States, there was a need to investigate the effects of early follow-up on heart failure readmission rate. A comprehensive literature review was conducted. This search was conducted using Mirabel University's library collections of approximately 133 scholastic databases. The search was limited to full-text articles in English language published from 2017 to 2023. There were peer-reviewed content as well. The initial search used keywords that included heart failure, readmission, transitional care, early follow-up, and post-discharge telephone call. The search indicated that early post-discharge follow-up through a 24 to 48-hour phone call and a 7 to 14-day clinic visit reduced the 30-day heart failure readmission rate. It was determined that quality improvement project would be conducted to address this problem. On to our next slide. We're going to be looking at the review of literature. A careful analysis of the most recent literature revealed several themes that support this quality improvement project. And we had 3 themes, which includes problems linked to heart failure readmissions, early follow-up interventions, effects on 30-day readmission rates. I'll start off with problems linked to heart failure readmissions. The delay in follow-up after discharge, non-adherence to the treatment plan, including poor compliance with daily weight, salt, fluid intake, medications, and lifestyle modifications. Heart failure is challenging for patients, families, healthcare workers, and the healthcare system. It increases mortality, morbidity, and poses a substantial economic burden on the patients and the healthcare system. We go on to early follow-up interventions. Interventions reported in the literature included a 24 and up to a 72 hours post-discharge follow-up phone calls and a 7 to 14-day post-discharge office visit with either a primary care provider, advanced practice clinician, or a cardiologist. The literature also had another theme, effects on the 30-day readmission rate, which showed that both telephone follow-ups and a 7 to 14-day office follow-up were beneficial in reducing the 30-day readmission rates. Follow-ups were also known to improve patient satisfaction and overall clinical outcomes. So we go on to the theoretical framework. Lowen's change theory provided a theoretical framework for this quality improvement project. There are 3 phases, which are known as the unfreeze, the change, and the freezing. All three phases have been known to be effective in guiding nursing reform. The unfreeze phase involves identifying the existing practices and procedures. Meanwhile, the change phase is a systematic implementation of a new project. And the freeze phase involves those modifications that must be adhered till they become routine practice. And then we become more specific for the scholarly project. The unfreezing phase involved identifying gaps in care. Then subsequently, staff and leaders were educated on the project goals and its benefits to patients and the practice. And then for the change phase, I, with the help of the facility, implemented a structured referral process from the hospital to the nurse-led heart failure clinic. Then patients received a phone call, which was a 24 to a 48-hour post-discharge phone call, followed by a scheduled 7 to 14-day transitional care management visit with either an advanced practice provider or a cardiologist. For the freezing phase, after the project had been implemented, data was analyzed to evaluate compliance with the intervention and to ensure that the project is sustainable. In this case, there was insufficient data to show that the intervention successfully reduced the readmission rate. Thus, further quality improvement projects of longer durations are recommended. So we go on to our next slide. We look at methods and designs. Site and Mirabel approval was received for this quality improvement project. Staff were educated on the project's goals and implementation strategies. A structured referral process was established with the help of our information technology department. Documentation templates were also established again with the help of our information technology department. Early post-discharge phone call, which was a 24 to a 48-hour post-discharge phone call, and a scheduled 7 to 14-day office visit was implemented. The population included patients or participants 18 years and older who were admitted for heart failure exacerbation between October 1st of 2022 through September 30th of 2023. Pre and post intervention data was collected on a data collection sheet and stored on a password protected computer. The pre and post test design was utilized to assess the effects of a 24 to a 48-hour post discharge phone call and a scheduled 7 to 14-day clinic visit on the 30-day heart failure readmission rate. The project employed a retrospective, quantitative, exploratory design. Nominal data was collected to evaluate heart failure readmission rates. Data was analyzed using a z-test to determine the difference between two independent proportions, which are the pre-intervention readmission proportion and the post-intervention readmission proportion. And we're going to go on to our samples. The setting of this scholarly project was at a hospital located in the southwest region of the United States. This hospital was a 117-bed acute care facility that managed heart failure patients daily. The facility also had over 50 satellite facilities that manage heart failure patients after discharge. So they're really familiar with that, managing heart failure patients. Initially, for the participants, 180 EMR were reviewed retrospectively. However, 38 met the exclusion criteria. This landed us at a final study population of 142 participants. The sample size allowed for adequate measurement of the expected variability with the pre-intervention sample size of 58 participants and the post-intervention sample size of 84 participants. We're going to continue with our sample. Age, ethnicity, and gender were among the demographic variables analyzed using descriptive statistics. Again, we looked at the age that were 18 years and older patients admitted for heart failure exacerbation, but we saw that majority of the patients who were admitted for heart failure exacerbation in both the pre and post intervention data were falling between the ages of 65 and 89 years of age. Then we looked at the gender. In the pre-intervention, we had male, majority of the patients were male. We had 55% male, which totaled 32 participants, and we had 45% female, which totaled 26 participants, and those who reported themselves as others were 0%. Then in our post-intervention gender, we saw 61% male, which were a total of 51 participants. We saw 39% female, which was a total of 33 participants, and those who reported themselves as others were 0%. Then we'll go on to our ethnicity. In both the pre and post intervention ethnicity, Caucasians were dominating. In the pre-intervention, we had total Caucasians were 49, followed by African Americans 5, and then those who reported themselves as non-applicable were 4. Then we go to our post-intervention ethnicity. 77 participants were Caucasian, and we had 2 African Americans, 2 Native Americans, and 3 reporting themselves as non-applicable. And we'll go on to our next slide to talk about a data analysis. And we have data analysis that is given here as a chart, and we're going to talk a little bit about it. The z-test for the difference of 2 proportions was used to determine if there is change in the pre- and post-intervention ratio. The z-test is a directional form of chi-square test. The p-value of 0.7825 is greater than the significance level of 0.05. Therefore, there is not sufficient information to suggest a decrease in the ratio from the pre to the post intervention. The achieved power of the study was 0.1890, which is considered low in strength. Then we'll come now to talk more about our results. So I guess we can't talk about the results without looking at what we even analyzed. So we looked at follow-up phone calls, and we looked at readmission rates to come up with these results as a z-test and a p-value. And when we look at our follow-up phone calls, we can see that the blue is pre-calls, pre-intervention calls. And we can see that, well, some people were making phone calls. Case management, they were making phone calls. There was a program called the Chronic Care Management Program. Chronic care management looked at patients with multiple comorbidity and high risk for readmissions, and they took those group of patients if they were volunteered to be enrolled in a study. And so they would call these patients post-discharge. So there was this care management program that was going on for the patients who had elected to enroll themselves in it. So we see that we didn't have any 24 to 48-hour phone calls. And then we now implemented this pilot study. So initially it was a pilot study, so only certain group of patients will receive this phone call. However, the hospital decided, let's integrate it so that everybody who got discharged from the hospital, it didn't matter if they had heart failure or not, received a phone call. So then our heart failure group will benefit from this, right? So 17 phone calls from these 24 to 48-hour phone calls were sent out to our heart failure group of patients. And we can see that the care management group also increased their phone calls on that post-intervention. But we're seeing here, well, some patients did not answer the phone call, but then we also see this group, greater than 50%, that are not even getting a phone call at all. So more work is still to be done, but we'll continue to talk about that as we go ahead. Then we look at the pre and post-intervention readmission rate, and we can see that the blue is yes. Were they readmitted? Yes. Were they not readmitted? Then we see the orange line. No. So in the pre-intervention group, 10 were readmitted, 48 did not get readmitted. In the post-intervention group, we had more patients. So we had a larger population, and we had 19 were readmitted. So then let's talk about the results. The results of the project showed no statistically significant difference between the pre and post intervention with a z-score of 0.7814 and a p-value of 0.7827. Thus, there is insufficient data to demonstrate that early post-discharge follow-up helped reduce the 30-day heart failure readmission rate. So we go to our next slide. We look at limitations. We had a population of 142 participants, which is lower than the recommended sample size of 152 participants. So like we earlier talked about, this was a pilot study, so it only allowed a subset of patients to receive the intervention. However, the hospital decides, no, this could be beneficial for everybody, so everybody gets this call. But we see that even when it was integrated for everyone to get the call, greater than 50% did not receive an intervention. Delay in establishing a referral process was also a limitation to this study. And even after a referral process was instituted, there was underutilization of the referral process, which led to a smaller sample size and fewer interventions. We also had a problem at the time. There were severed contracts with Blue Cross Blue Shield, so patients out of network were considered an exclusion. They met the exclusion criteria. They were excluded from the study. So due to these severed contracts, we had patients that will go see other providers that were their in-network provider, and part of our exclusion criteria were, if we can't follow up with them, then how can we consider that? So these patients out of network, due to the severed contract with Blue Cross Blue Shield, this hospital was serving about 40% of their patient population they served had Blue Cross Blue Shield. So that really limited our sample size. Then we also had staff members that were resigning. We also had inadequate publicity, which decreased system-wide awareness of the program. So we'll go on to discussions. Heart failure typically have these patients with heart failure, they typically will have multiple comorbidities and complex medical regimen. Post-discharge heart failure services are warranted. Transitional care interventions with a 24 to 48-hour phone call and a follow-up visit are used to monitor and guide patients during this vulnerable period immediately post-discharge. Well, we looked at our results that showed insufficient evidence to show that a 24 to 48-hour phone call intervention was successful at reducing the 30-day heart failure readmission rate. The study still had a lot of strengths: retrospective, cost-effective, and timely evaluation of the intervention's efficacy. So it was a retrospective study, which was also beneficial, was cost-effective. No conflicts of interest. And clearly defined exclusion and inclusion criteria. There was also rigorous data collection method, which enhanced the validity and reliability of the study. Consecutive sampling reduced the risk of bias. HIPAA was upheld. Participants also expressed positive feedback. And we still see timely post-discharge follow-up remaining essential. Now, in retrospect, many actions might have been taken to enhance the results of this scholarly project, which might have produced statistically significant findings. If this project were repeated, measures would be taken to lessen its barriers, limitations, thus increasing the volume of intervention, sample size, and likelihood of more significant findings. Early post-discharge intervention continues to be recommended in guidelines. Therefore, it is essential to recruit support from stakeholders, broadly publicize the project, and allow for a longer duration of the intervention. So a combination of the project's barriers and facilitators contributed to its outcome. So go on to our next slide, implications for practice. Transitional care interventions such as a 24 to 48-hour post-discharge phone call help identify and address gaps in care. It enhances patient education and empowerment. It provides quality care. It improves health outcomes and adds to the body of knowledge. Implications for future research. Though the results are not statistically significant, it is clinically significant in in enhancing patient education, empowerment, and adding to the body of knowledge. More quality improvement projects should be completed over a longer duration with a larger sample size. Of course, the strengths and limitations of these studies should guide future studies. And then we'll go on to our conclusions. To conclude, the aim of this project was to explore the effects of early post-discharge follow-up on the 30-day heart failure readmission rate and patient outcomes in adult patients admitted with heart failure. During the 24 to 48-hour post-discharge phone call, patients received education, guidance with disease management, and medication adherence. The results of this project does not provide sufficient evidence to suggest that the intervention successfully reduced the 30-day heart failure readmission rate. Thus, a change in practice was not recommended. Further studies are required to explore the benefits of early post-discharge follow-up on heart failure readmission rate. That brings us to the end of the presentation. Thank you for listening. At this point, I'll open the floor up to questions. So let me know if you have any questions. And I also have my email at the end of the slides. So if you think of any questions, please send me an email and I'll go on to our references. And these are all the references that we utilize for this project. And we have more references. And again, this is my email. Thank you so much. If you think of any questions, shoot me an email. And thank you so much, and you have a great day.